Beautiful day, JPS. Testing 1, 2, 3.
Good afternoon, everyone. Thank you so much for being here. I'll move forward with the agenda. We got a fairly full agenda here this afternoon. So again, welcome. We will open this meeting at 1:05. Our first order of business will be Chaplain Ms. Franklin. Leanne, if you'd come up, please. Leanne's Director of our Pastoral Care and Ethics here at JPS. And then if you would please join me in the Pledge of Allegiance after that. Leanne.
Good afternoon. As I was coming in this morning, I just want to share what happened. It was very early, and my heart and my head were full of this patient who's physically very ill and has never had love, and just my heart was very heavy thinking about what we all could do to help her. And as I was walking towards administration to discuss this case, a woman was coming down the hall singing beautifully, just in the lobby, and I thought, that's so typical of how it is, that someone's receiving the worst news ever while somebody is celebrating the greatest thing that ever happened. And so I'd like to begin today with a prayer that acknowledges the both-andness of what we do. Will you join me in prayer? We gather today together, and we ask for peace in the midst of problems, for clarity in the midst of confusion, for courage in the midst of uncertainty, for unity in the midst of difference, and for joy in the midst of all. We pray all this in your holy name. Amen.
Leanne, thank you.
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I think Ms. Wilson. All right, our next item of business would be citizens wishing to address the board. I have been advised that we do have a citizen. Is Mrs. Wilson here? Yes, Ms. Wilson. If you'd like to come right up here to the podium, please, ma'am. And I'll just have to reiterate what I have to say every time we have someone. We have a 3-minute rule. And
I thought it was 5.
no, ma'am, it's actually 3, but you go right ahead, and if you'll start, the floor is all yours.
Along about 2006 or 7, I became aware of another person's name associated with my medical record, a Hispanic person with a Grand Prairie address. I saw it with my own eyes on your computer. I asked the employee, the clerk, please don't delete this, please don't erase this, because I was hoping to obtain a law enforcement investigation. There are threats to my personal safety. So I'm afraid to be here, but so I didn't pursue the matter. And 10 years later, I still have not obtained a law enforcement investigation. There are problems. I only have 6 copies, but I came to bring you copies of documents that prove without question that multiple employees have participated in generating multiple accounts with my name, and I suspect it may go back to 2006 or 7 when I provided my Social Security number. And I believe I've been sick with cancer now for 8 years, and I've not only received no diagnosis, I've received no treatment. And yes, I believe the FBI. I've provided information to the FBI. I believe they're sitting on it because they've obtained other information from me. They got what they wanted, and I believe I've just been left to fall over dead, or at the very least become so sick that when my colon rots and has to be surgically removed, it'll become an emergency situation, and there will be no time for me to consult with anybody about anything. And so I believe I've just been left to die. And the problem, when I asked if I couldn't partition off my record and generate a new, start a new record, I was told, no, that can't be done. And all I know to say is, this is not just an accusation against the hospital district. It's medical records at other facilities, same defective records at other facilities, and it's pretty much any piece of paper that has my name on it, whether it be a visa bill, divorce papers, everything. Every piece of paper that contains my name, I can find defects in, and I believe would not hold up in a court of law. And I believe I've been living in a state of subjugation and peonage now for 28 years, and there's been no law enforcement investigation. I've been arrested 6 times, apparently for other people's purposes, but it gets me nothing. And peonage was abolished in 1865, the passage of the 13th Amendment, over 150 years ago, but that's my claim. And I know that's not your problem, but here's these documents. There's multiple account numbers involved, and it's not getting, I believe I'm being denied basic medical care as defined in both state and federal statutes. And just generating, I don't even think at this point generating a new medical record is necessarily going to help me. I don't know. I mean, I'm not a police officer. I'm not the FBI. I'm not a computer person. But I bring this to you because I feel like I'm up against a shell game, and no matter who I turn to at this hospital, I'm switched. Somebody else is taking care of the problem, and somebody else, and somebody else, and then it gets back to the original person. The problem's been solved. No, the problem's not been solved, and I'm alleging that I've had cancer for 8 years now with no treatment. Here's 6 copies of some documents. It's every piece of paper with my name on it.
Ms. Wilson, we appreciate that, and so you'll know, we will turn those documents direct to General Counsel for the hospital. They went from you straight to him. So, again, thank you very much. And Mr. Adams, if...
Police officer where I can be located in the daytime and contact information.
Okay, thank you. Is there any other individuals we have, Scott, for signed in? We do not. Thank y'all very much. I will then move along to item number 4, which is the approval of the minutes. And there's several of them that I think we need to take these by individual. There's the approval of the minutes of the Board of Managers meeting of November the 8th. If there's any questions, we would so entertain them. If not, I'd entertain a motion.
Move approval of the November 8th minutes.
I have a motion by Mr. Bose, second by Dr. Weber. All those in favor say aye.
Aye.
The nominating committee minutes of November the 8th, same day. I have a motion for approval by Mr. Montgomery, second by Dr. Simmons. All those in favor say aye.
Aye.
Opposed, no. Thank you. And the Finance Committee meetings of November the 15th. Is there any discussion? Mr. Montgomery I assume he's going to make a motion to approve the finance. He's chair. And so I have a motion. I have a motion on his third cookie. He's made a motion to approve those meetings. We were there. That is, he'll get a 1099 for that. But anyway, so I have a motion. Do I hear a second? I have a second. All those in favor say aye.
Aye.
Thank you all so very much. Obviously, the board chair comments, and I'll make this very quick. Leanne was talking about lovely ladies singing and kind of made her day. I was hectic leaving the office downtown to get here, and I'm on 8th Street, and I couldn't help but notice there's a sign now that says JPS Center for Cancer Care opening soon. You just get a warm feeling. And so, again, it's just, you just never know when you hear JPS. I know everybody gets so caught up, it's the buildings and all that. No, it's the mission and what we do. So I know, Angie, I know you're working on it, and that sign looks great out front, and that opening soon will probably change. But it's not what the building does, it's what we're going to do within the building that makes us JPS. So thank y'all for that. A couple of things I will say. Obviously, the holiday season, I wish each and every one of you in this room, to the board, and I know the board with me wishes each and every one of you as employees and staff in this room, we wish you and your families a very happy holiday. We have a little get-together this evening. We certainly hope if your schedules are available, you could certainly join us that. One thing I like to do, I see her back there grinning, but I see Michelle Green. I want to congratulate you on your new job as diversity. Michelle is now our Chief Diversity Officer here at JPS, and again, congratulations on that. And the last thing is this. Robert's won an award every month I've been up here this year. Here we've been talking about awards. And of course, Tricia got in there last month because she won a national award. But, I couldn't even leave and go to the east over here and pick up the Dallas CEO magazine, which just came out. You know, and I kid him about being a legend over here. I want y'all to know, in all fairness, Robert just was recognized as one of the top CEOs of the 500 corporations in Dallas also. So, Robert, congratulations again. It continues on. And again, I know at the end of the year we tend to wrap up any other business, and we've got certain items here we'll have to do. But on behalf of this year, it's been a phenomenal year as we come to 12/31. Appreciate all the board, what we did. I appreciate the Blue Ribbon Committee. Appreciate the joint work the Commissioners Court, the Blue Ribbon Committee, and this board did. You know, we've kind of passed talking about it. That big bond package, we spent a lot of the last few years thinking about it, working on it. It's now kind of behind us. Now the real work starts. So, but again, I don't want to be remiss and say one more time, thanks to everybody on this board. Obviously, thanks to G.K. Manus and the staffs downtown. But I had the pleasure of attending Robert's leadership. I stuck my head in here one morning here just recently, and I had a chance to tell the employees, I'll say it again, it's what you do every day that makes JPS what it is. And we wouldn't be passing bond packages and getting things done if the perception of the people in this community didn't have faith in this institution. So thank y'all very much, and I'll kind of end on that note, Robert, and turn over to you for your CEO report.
You bet. Thank you, Mr. Chairman, and thank you for your kind remarks regarding me. The best part of any award that you're nominated for is when your staff surprises you and they show up at the event, and that happened to me in Nashville, and the chairman showed up to that, and so did staff. They flew all the way up there on their own dime to do that. That's the greatest award, and they did the same thing in Dallas. They showed up to surprise me, and I don't do particularly well at those functions, and so I was standing around feeling and looking awkward, and then the staff was there, and they're an incredible group of people, and I couldn't be more thankful. That was the best award, is to be surprised by them showing up. So the staff is what makes everything for me. They did, and my wife surprised me, and she flew up too. I drove underneath all of them. But they really missed out on the countryside. It's a beautiful trip from here to Nashville, and I feel sorry for them for flying because they didn't get to see the beauty that I saw. But thank you, former chairman. A couple other things I want to mention. When anybody is a patient here and we feel that we have done everything we possibly can do, there's a somber nature to all of us when somebody comes in and says, I need more, and we're just trying to figure out how to help with any patient and any of them. The 1.2 million patient encounters we have, if we don't feel that we've either done right or we can't convince that person how to help them, it's a somber feeling for us. And one of the things that helped this week, because those happen every day, one of the things that Leanne and her team do, which is carrying on a tradition that Dan did before her with the blessing of the hands. And wherever your spiritual belief is or non-spiritual belief, the key to this organization is the use of your hands to be able to, from a surgeon's skill to the skill of the team members that go out and shake a hand or high-five people in the hallway. And so the Leanne and her team coming around and blessing every employee's hands and spending the time and letting us sort of take a minute to reflect was really powerful. And those are neat things that help offset the challenges we have when we can't help. And so we do everything we can, but that blessing means a lot, and it sort of grounds you in where you need to be and what you need to do. The room here, I can mention this because Wanda Peoples is not here. Wanda took some time off because her granddaughter came down from Alaska. Her granddaughter, I believe, is 4, and her son and her daughter-in-law. And there is one thing you never do, and you do not stand in between a grandmother and a granddaughter. So Wanda said, "Can I take this week off?" And my answer was certainly. But before Wanda left, she decorated this room, the Christmas tree. Those wreaths are made by Wanda. And Wanda puts on a Crafts with the CNO project. And there were 100 people in this OPC making beautiful ribbons and things for holiday spirit. And all of them left here glowing because all of them had an immeasurable amount of glitter on them. And I think some of them may have been on the bows and the ribbons, but most of it was on Wanda. So should you see Wanda between now and March, she will have a glow to her due to her granddaughter and her glitter. But we owe Wanda a lot. She does a whole lot to make the spirit of this place thrive, and it means a lot to us. The pictures before the board meeting that some of you may have seen on the screens were a lot of celebrations. We had our Patient Experience Award celebration where we gave awards to primary care, particularly the folks at Diamond Hill and Poly and the Employee Health South Campus, Healing Wings, Stop 6 or Top 6 as they're like to be called, and our Magnolia Clinic for the incredible work that they did. We recognized the primary care top performers, which was Healing Wings, and once again, Stop 6. They did an incredible job. We recognized our outpatient providers who have really come up in their scores and done some incredible work. We recognized the emergency department and the clinical decision unit, which are tough units. I was down in the emergency room the other day. We had 55 patients holding, and that's because we do such a good job in the ED, but it's a challenge to get available beds, and it's just hard. It's hard. It's not that we're failing. We see those patients the minute they come in the door. It's trying to get them admitted and having the space, and their scores are all up. We recognized units for the fact that they hit top quarter in their goals. 2 North and 2 South, Tower 6, Pavilion 4 in the ICU. If you've never been to our ICU, it's one of the more challenging ICUs you're ever going to see because of the acuity levels. And the fact that those wonderful nurses there continually rank every year in the top quartile is pretty amazing. And then we recognize 2 units for where they have been and where they have come. And we recognize Tower 2, which was in the 39th percentile, and now they're in the upper decile in 2018, and also Tower 7. So we have some really high-performing groups, and we just took time to take some pictures and have some joy, and it was a great opportunity. Mr. Chair, I look forward to celebrating tonight, celebrating the year, celebrating where we've come. I think it's time for you as board members to take a breath. I always tell staff to take a breath. And look at what they've done. You all need to do that. And I hope you'll do it tonight and take a breath and realize how far you've moved this organization because you've been pretty phenomenal. And I wouldn't have any other board. You're a good board, and you're very committed to what you do. And I'm greatly appreciative. So tonight, night of celebration. For those of you who can't make it, I hope you'll take the time to just take a breath at home and just realize the good stuff you do for this organization and you personally do for me. So, Mr. Chair, that's all I have.
Thanks, Robert.
You're more than welcome.
I meant to say this as you mentioned the board. I went back and kind of checked the attendance. You know, there's 11 board members, and we serve on a lot of committees, so you've come to a lot of meetings we all know. I'm not telling this board anything they don't know, but I kind of went back and glanced across the attendance, and we've always had 9, 11. You know, look at us today. I've talked to DT, who's not here today. DT's in Atlanta, Georgia. Actually, Randy talked to his wife last night at a function, and then I talked to him. He sent me a text. I talked to him this morning. And I spoke to Trent this morning also. Trent's out of town, working at a municipality down south. So, again, the 2 that are not here both reached out, and I was talking to both of them. So, again, thank y'all so much for your attendance. So we will move then to item number 8, which is, Chet, it's all yours for the medical.
Chet, before, if you can pardon me for my interruption, you know, we did have apologize. We had the quality fair, and the posters are out in the hallway, and I didn't know, Chet, if you were going to do that or not, but the quality fair has been pretty amazing this year, and the team, so I didn't want to take any of your thunder away in any way, but that's quite a deal. And those of you board members, be cautious, because if you make eye contact with us, you will be a judge next year. So just be aware.
Chet, before you start, seeing how I'm sitting here in front of our auditors, you know, 7 becomes before 8. So, you know, it's a perfect time for me to back up and say, Chris Clark's here, obviously, from BKD. Is there anything, Chris, you or Sharon need to add or say if you'd come up? And so, yes. Thank you.
I thought maybe you didn't want to end the year with an audit presentation.
Depends on what you have to say.
Yeah, depends on, yeah, that's a good point. It depends on what, yeah.
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 No pressure. Well, thank you for having me today. For those that I haven't met, I've met a number of you over the years. My name is Chris Clark. I'm an audit partner. I'm an audit partner with BKD based in Dallas, and am the partner in charge of overseeing the annual financial statement audit here at JPS. So I've got a brief presentation to share with you today. Please feel free to stop me as we go along, and I'll be happy to answer any questions that you might have, and then we'll have a couple minutes at the end for questions as well. Included in your board materials are drafts of our audit deliverables. You've got a draft of the audit report, a draft of the single audit report, which is your grant compliance report, and then a letter from BKD to the Board of Managers that communicates to you all the things that audit standards require that we share with the board as it relates to audit results. I've summarized the details of those on this screen, so I'm going to not refer to these documents, but will instead reference the items that I've included in the slides here. So I've got a brief agenda. I want to go through the required communications, show you the current year financial results and how those compare to some prior years. There's a new accounting standard that I want to share with you, and then I've got a few brief industry comments at the end. So the first thing to note is that we've got two audit reports that we're prepared to issue: the annual financial statement audit related to your financial statements, and then the grant compliance audit that I mentioned. As you probably noticed in the materials, there's a draft stamp on those documents. We come to this group in draft form intentionally to give you an opportunity to hear the results and ask any questions that you might have. But we are complete with our audit procedures. So once you've had an opportunity to hear my comments and approve the reports as provided here, we'll be in a position to wrap up the audit steps and remove the draft stamp and add a BKD signature to the opinion that you see included in the materials. I've noted here that we're prepared to issue an unmodified or clean opinion on the financial statements. That means BKD is providing a reasonable level of assurance that the financial statements are accurate and complete, and that the footnotes also contain all the information that a user of the financial statements might need to know to better understand the context of the financial position of the organization. In terms of the grant compliance audit, and these are federal grant awards, any organization that receives more than $750,000 in federal grant awards is required to obtain a compliance audit. In that audit, we evaluate the expenditures to determine if there's any costs that are questioned that might be inconsistent with the program rules of whatever grant you were awarded. We had no question costs and no material weaknesses or significant deficiencies in controls over that process to report to you. I'd also like to pause here just to mention that in both the financial statement audit and in the grant compliance audit, we received all the cooperation that we would have expected to receive from your management team as well as the finance team. They were prepared when we got here. We moved through the process very efficiently, and they were attentive to our team while we were here conducting the audit, and we're very appreciative of that. The next thing that I want to cover are the significant risk areas in the audit. There's a letter that was circulated to the board early in the year that outlined the summary of our risk assessment process that we go through to identify the key risk areas in your financial statements, and I've summarized those for you here on the screen. Sometimes these issues can be specific to an organization because of some internal control related risk that exist, and then other times they're inherent because of the type of organization that you are. And I would say that the items that you see listed there on the screen are consistent with because you're a hospital and a hospital district, these are very consistent with what we see with the other hospitals that we worked with. And those include accounts receivable, third-party payer settlements, which are settlements from Medicare and Medicaid cost reports, as well as your Medicaid waiver programs, reserve for self-insured risk, the valuation that you place on your property tax receivable, and then your net pension liability. On the right side of the screen, you'll see key significant financial statement disclosures. We're also required to disclose to you what we view as the most significant disclosures in the financial statements. Those include Medicaid reimbursement programs because they're so significant to your operating results, the details behind your defined benefit pension plan, and then the nature of the property tax revenue and how that funds the operations of the district. This slide summarizes for you the results as it relates to any changes that occurred in the financial statements. So here we would disclose any significant audit adjustments that were recorded. There were some balance sheet reclassifications that we have annually made for external financial statement reporting. So those had no impact on your bottom line, just changes in the geography of some things in your balance sheet. And then, as noted there on the screen, we had no adjustments that we recorded that impacted your net income or your excess of revenues over expenses. So the financial results for the current year that were reported to you on an interim basis when management closed out the year should be consistent with what you see reported in the financial statements. There were some variances that were identified that we considered for materiality, but ultimately did not record as adjustments in the financial statements, and those were included on a schedule in your materials, and I've summarized those here. We identified about $1.1 million of liabilities that existed at September 30 but were not recorded in the financial statements. Those almost entirely were balance sheet related, so they were either inventory related items or capital related items. So that issue in and of itself would have had very little impact to your bottom line. There was an estimated overstatement of amounts due from third-party payers, and this relates specifically to Medicaid uncompensated care pool funding. The Wednesday before Thanksgiving, the state published a file to announce what the final allocation of the 2018 UC funding would be. And the number that was allocated to JPS was about $3.6 million higher than what had been estimated in the financial statements. That's information that nobody knew at the time the financial statements were prepared. And then the next item there relates to patient accounts receivable. We've, over the last few years, have been monitoring your cash collections as compared to the receivable that is reflected at any given year end. And you have a few years of history of successfully collecting some accounts that had been written off to bad debt in previous years. And as we evaluated that and considered that in conjunction with your current year mix of patient receivables, we felt that that balance could be increased by about $4 million in the current year. And so we considered those three items and ultimately determined in conjunction with management that those issues were not material to the financial statements overall. As you can see, it was less than 1% of an impact on total assets or total equity. And had we recorded all of these things, it would have increased your excess of revenues over expenses by about $386,000. Any questions on any of those before I move on? The next several slides will show some summary financial statement information as well as some key ratios. And you'll see some, and I'll make comments about some comparisons to your peers in the industry. And so I just wanted to point out that when I show a district average, I've included these 5 organizations. In addition to JPS, I've included the county hospitals in Dallas, Harris, Bexar, and El Paso counties. So here's a look at your balance sheet over the last 5 years, and there's a few things that I wanted to highlight here for you. If you look at cash and short-term investments, as well as non-current cash and investments, you'll see a growth over the last 5 years. If you go back to 2014, and I'm going to try to use your fancy technology here, so I'm looking at these lines here. So if you look at the subtotal of those two lines, back in 2014, you had about $423 million of unrestricted cash and investments. And when I say unrestricted, I include in that any internally designated funds that you have. If you look at the end of 2018, you had about $556 million of total unrestricted cash and investments, which is a growth of about $133 million over that 5-year period. If you look at your property and equipment line here, you can see that really over the last 5 years, that's primarily you've been in maintenance mode in anticipation of the projects that you've got upcoming here. And so that has declined with depreciation over the last 5 years. All of that resulting in really consistency in your total assets Over the last 5 years, you were at $950 million back in 2014 and just under $1 billion in 2018. Over the same 5-year period, your net position or equity here has increased by about 8% from $759 million in 2014 to $823 million in 2018. Another thing that you might notice on the balance sheet are your deferred outflows of resources and deferred inflows of resources. Those relate specifically to your pension plan. There are valuation techniques that occur in measuring your net pension liability, and there are certain changes that occur within your pension assets and within your total pension liability that are deferred and recognized as benefit expense over an extended period of time. And so that's what those matters are. Those balances will be amortized into employee benefit expense over the next 4 to 5 years.
Chris, on the cash and short-term investments, those are year-end numbers?
Those are year-end numbers.
And they look really big to me. Is that because we've got cash sitting that we receive through our tax revenue that's part of our operations?
It would be a combination of cash that you've generated from operating activities and property tax revenues, although I would say that if you look at it, and this plays into some of those district averages I mentioned because, and actually I'll just go to the next slide, which is days cash on hand. If you look at this, Bexar County is a 12/31 year end, and Harris County is a 2/28 year end. And if you think about that timing, a lot of tax revenue comes in between October 1st and the end of February. So they're reporting their year end when their cash balance has peaked. Here, you probably are reporting at one of your lowest cash points because you've not yet collected the 2018 property tax revenue. So you'll see those balances grow over the next few months. And so if you look at that green star, so at the most recent fiscal year end, for those 5 districts, the average days cash on hand was just over 150 days. And if you dig down into that number, there's a few things that's driving that down. Number one, the hospital district in El Paso operates with very little cash. So at any given point in time, their days cash on hand might be in the 10 to 20 range. Bexar County in San Antonio and Harris County down in Houston, they have historically reported 220 to 230 days cash on hand, and Parkland over in Dallas is somewhere between 90 and 100 days cash on hand. So that kind of gives you an idea of where each of those districts sit. At year end, you can see that in terms of a Moody's average, you're right in there in the mix at 198 days at the end of fiscal 2018. And that's trended down over the last couple of years. As you can see, you were at 241 back in 2016 and 216 back in 2017. There's different things that play into that. Obviously, your operating expenses continue to increase every year, just as all hospitals' operating expenses do. You've also received less funding from the waiver programs over that 5-year period, which is all impacting. What's that? Okay. Next item here is days revenue and receivables. So this is on average how long it takes you to collect a patient account. You've hovered around the 50-day mark for the last few years, which is right in line with the overall industry averages, a little bit lower than the hospital districts. So I would say from both a valuation and efficiency perspective, you're in a sweet spot in terms of net days and accounts receivable. From a board oversight perspective, you would monitor this for valuation concerns. So if that starts to trend up, either you've got valuation issues on AR or there's some efficiency issues in terms of collecting patient accounts, but you've been very stable over the last few years.
How is this defined? Obviously, if something's uncollectible, how does that mix in there?
We take your net patient service revenue, which incorporates bad debt expense, so all those accounts that are written off, divided by 365 to come up with an average daily revenue number. And then we take your net patient accounts receivable and divide that by that.
Right. How long does uncollectible debt stay on the record before you move it off and say, well, I mean, obviously,
yeah,
if we didn't do that, then...
It depends on the payer. And so you look at historical averages on any insured accounts, but your self-pay accounts, which are largely uncollectible, those are written off relatively quickly unless they qualify for your connection program or some other program.
I guess the question is there a policy that says that if and maybe it's another question, when we're collecting information, when we're doing collections, do we say after 60 days we're going to call it uncollectible or move it outside of this, or is it 30 days, or what is the rule? Do we have a rule?
I can't recall what the point in time is when you actually write an account off in your patient accounting system. From a financial reporting perspective, if you've got an account that's uninsured, through your valuation process, you essentially say that nearly 100% of that account is not going to be collected, so it's not reflected in revenue or in patient AR.
If we're just assuming that we're not going to get it, then that makes sense too.
Yeah.
So yes, our policy excluding self-pay accounts, really there's not a cliff as far as a time frame where we would write an account off. There are commercial accounts that we might deem uncollectible on day 20. There are commercial accounts that we continue to work on for, 8 to 12 months. So it's really an account by account. From an accounting standpoint, what we do is we try to reserve what we feel like is going to happen at the time that charge is created based on historical averages, and it's a pretty complex and detailed calculation. So when you look at the face of the income statement, and we have net patient revenue there at the top of that income statement, it's charges less all of our estimates, because very few accounts have been actually paid or collected on.
Right.
So what the day's revenue and receivable shows, at least from my standpoint, is it takes us on average about 50 days overall to collect on an account.
And the assumption is that self-pay doesn't pay is not part of this calculation, what you're saying.
Effectively, it's not, because when you start with your
The
net,
assumption is 0.
we reserve right away probably about 90% of a charge for a self-pay. And then as it ages out, we continue to reserve that. And then all accounts are reserved for probably by about 6 months out. Now, if you look at a functionality standpoint, we continue to collect. It's still, people are still calling and working with the insurance companies, but you don't usually see it on our income statement. And if we recover it, that's what Chris was talking about. We do a good job recovering things that are past that 180 that have been fully reserved for, to actually get the cash in the door.
Thank you.
Sure.
The next slide I have for you relates to your pension plan, and any organization with a defined benefit plan should monitor the funded status of the plan. I think we've talked about in years past how there's a number of municipalities with large unfunded liabilities related to pensions or post-retirement health benefits that have gotten those organizations into some trouble. You can see here that you're nearly 100% funded on your pension plan, which is higher than the other districts on average, as well as in terms of general industry averages, which is about 80%. One thing that I would point out here, that's largely driven by the discount rate that's used in measuring that liability, which is 7.25% here. If you decrease that by 1%, the liability jumps to $34 million. If you increase it by 1%, you go from a small net pension liability to a net pension asset of $25 million. So there's some judgment involved in this, but that 7.25% is heavily scrutinized by the actuary as well as your auditors when we're evaluating it.
We'll take that number.
Cash to debt. Obviously, because you've borrowed very little money over the years, the comparison of your total cash to total debt, there's a huge delta there that exists, which differentiates you currently from the industry, and you can see the district averages and the Moody's averages there. Your numbers are actually driving that district average down some. Obviously, as you begin to borrow money, that will change. If you look at hospitals like Parkland and UHS down in San Antonio, who have already done larger bond issues for facility enhancements, right after those years where they borrowed that money, they had more debt than cash, and so you're going to see some changes occur in this ratio, which will be anticipated and planned for in the coming years. Here's a look at your income statement over that same 5-year period. A couple things that I wanted to point out to you that has an impact here, and it has an impact at every hospital in the state of Texas, and that's this supplemental Medicaid funding line. You can see back in 2014, you recognized $185 million from the various Medicaid waiver and DISH programs, and it's $132 million in 2018. So just in the current year, you see that $17 million decline. And if you look at your very bottom line over that same 5-year period here, and you see those positive numbers back in 2014 through 2016, and then negative numbers in 2017 and 2018, that's directly attributable to the decline in that funding. I think you've done a good job at managing your operating expenses over that year, so that impact of that decline in the funding hasn't had a more material impact to your bottom line than what it has. This slide compares your cash collections to your net revenue, and we look at this from an audit perspective when we're testing your patient accounts receivable. You can see that you've got some years where the blue bar, which is your net revenue, is a little bit lower than your cash collections, which is the red bar, and vice versa. We want to make sure that when we look at this over a 3 to 5 year period, that you've collected roughly 100% of the revenue that you've recognized, and that's true here. If you look at the detail of the numbers on this chart, you've collected roughly 100% of the revenue that you've recognized over the 5 years. So that gives us comfort that your financial statements are materially correct from a revenue and accounts receivable perspective. This chart compares your total uncompensated care to gross revenue, the red being charity care related charges that are written off to charity care, and blue being bad debt expense. You see over the last few years, the total uncompensated care burden has remained relatively stable, but the delta between charity and bad debt has changed. This red bar in the current year is largely driving how much funding you're going to get from the Medicaid UC pool in coming years because of some rules changes to that program. And so the more of this uncompensated care burden that's being designated as charity care will have funding implications for you from that pool in future years. Lastly, I've got a summary of property tax revenue here, and so the bars show you the total property tax revenue dollars that each of these organizations receives and what percentage of their total support that makes up. And you can see you're at 38% as compared to some of the other districts. These percentages and dollars are very consistent with prior years. Any questions on any of the numbers?
Go back. How does El Paso pay its bills?
Well, they're the one that has, a handful of days cash on hand, and so that is a challenge for that organization.
That was
well said.
Yeah. When are you going to announce what office you're running for? Wonderful, well put. But it is challenging when you start feeling low. We can always have you go visit El Paso.
Question. I noticed that Collin County and Travis County, of course, don't have a system like we have, but they still have taxpayer compensated care of some sort. Mm-hmm. Is there any way to compare these systems with those systems in any cogent way?
Well, the challenge there is in some of those markets, particularly Collin County, the uninsured rate in Collin County is very, very low. And so the revenue that might be coming from public sources to support the uncompensated care that does exist there, I just don't think it would be comparable. We definitely could pull together statistics, though, to show in each of those counties, in every county in the state of Texas,
Right.
what the total uninsured rates are, what total uncompensated care costs are, and how that compares to what public support is coming in through, whatever means
All right,
there are.
but Travis County has a system, right? I mean, they don't have a big hospital like we have, but they still have a system of some sort, do they not?
Right, and I don't know exactly how Travis County works. There's in other hospital districts that exist in the state where there's a district but no hospital attached to it.
Right.
Those districts continue to collect property tax revenue, and then they have programs for the uninsured to receive care at different facilities, and they'll pay those facilities for providing those services at some agreed upon
Yeah, but
rate.
you could call it kind of a voucher system of some sort.
Right.
Yeah. It'd just be helpful, I think every once in a while, we need to take stock and say,
Sure.
are we doing this the best way, right? And so, and anytime we can get around to doing that's a good idea. So just next time we do something like this, I'd like to see that kind of response.
Yeah.
Just to see what we're doing different from another entirely different approach.
Sure.
As a comparison.
Yeah, we could definitely pull some data together for you on that.
Thank you.
Any other questions? A couple of last comments I have for you. There is a new accounting standard that will affect you in coming years, not imminent, but I wanted to go ahead and make you aware of it, that currently all of your leases qualify for operating lease treatment, which means you don't reflect any asset or liability on your balance sheet for that. The expense runs through based on how you pay monthly for those lease obligations. When this standard is adopted in a couple of years, you're going to have all of your lease obligations will be reflected in your balance sheet. So you'll have a right to use asset and then a lease liability. So it's going to change the look of your balance sheet. The idea being that it's a more transparent way for users of the financial statements to fully understand future cash commitments of the organization. A couple of comments on just from an industry perspective. I've kind of summarized here what we refer to as twin pressures, which I think every organization is experiencing right now, and that's operating costs that continue to rise at a faster clip than reimbursement rates from payers. And so I think you see that here, you see that at all types of hospitals, and that's driving some of the changes that you see in the industry as it relates to mergers and acquisitions. Even large organizations like Baylor Scott & White and Memorial Hermann are looking for economies of scale because of that, because of those issues that exist. I mentioned that the UC pool is changing, and one of the comments that I have down there towards the bottom is ongoing evolution of funding uncompensated care. In addition to changing how the UC pool will be allocated in future years, you may be aware that CMS and HHSC have recently requested information on all of the affiliations that exist in the state of Texas that have historically been the foundation on which the UC program has been that it functions on, scrutinizing some of those relationships. So I think as that starts to continue, you're going to see changes as it relates to some of those programs, which could ultimately affect how the UC dollars are allocated. That's all I have. Be happy to answer any additional questions.
Anybody have any additional questions for Chris? If not, I would entertain a motion for the acceptance of BKD Auditor's Report for year-end 18. Have a motion by Mr. Montgomery. Have a second by Mr. DeBose. All those in favor say aye. Opposed, no. Chris, thank you very much, and thank you for a good report.
Chris, I want to thank you on behalf of the staff. I also want to make sure that the reason Chris did not take the oxygen out of this room is because of Sharon, Marty, and Ben and the finance team and the work that they put into this. And accolades go to you. That is a hard budget to put together, and it's hard to get that auditing report out like that. But you guys did a good job, and your scrutiny and the way the ethics of BKD should be complimented, and I'm thankful.
Thank you. Appreciate it.
Chris, thank you again. Chet, I'm going to deviate just a little bit. I think we have a guest here that I'm going to ask if she would like to come on up. We have the Honorable Mayor Betsy Price. I know she just left a luncheon and she's got some more appointments. And Mayor, if you'd just like to, the podium's all yours, or microphone, or anything you like.
You know, I'm the Texas gunfighter. I hate having people to my back. Or maybe I'm guilty of something.
Yeah.
I don't know which it is.
We've checked them all. They're okay.
I'm very envious of his comment on your pension, especially in light of what we've been through the last. I won't say, Robert, that it made my day.
We went over Chris's presentation except that line.
There's hope. After our vote Tuesday, there's hope.
There is.
We're getting there. I just wanted to take a minute, and I'm sorry to interrupt your meeting, but I wanted to chance to formally thank this board and to thank all the JPS staff for your help when Officer Garrett Hull was killed. But more than that, just the continuing care. Fortunately or unfortunately, Garrett is the only officer we've lost in the 8 years I've been serving, but we've had numerous others who ended up here for gunshot wounds or broken legs and all. Without exception, their care is phenomenal. And for you board members, you've got to know that Robert and JR, who's hiding back here, I get a message from them as soon as one of our officers or one of our firefighters or code or anyone is admitted. They'll send me a message and say, we're not going to keep them, you don't need to come, or you do need to come, and continually keep me updated. We could not ask for a better partner than we have in JPS, and I'm very proud that we're able to send our folks here and that you take the time to give them extra special care, and they really know that that's rare. Because we've had them in other hospitals, and they do a great job, but they get incredibly great care here at JPS. So thank you all for inspiring your staff, and for all the staff members for your service to the city of Fort Worth and to our employees, but mostly that you care about them as individuals. So Merry Christmas and Happy Holidays.
Mayor, thank you very much, Mayor. I also appreciate you taking the time to do this because we know how busy your schedule is. And I'll also be remiss on behalf of this board, and I'll also thank you for recently your championing our cause for the bond election, because you stepped up and you had great leadership in that program. So I think I speak for this entire board. Thank you very much for what you did.
Well, it'll benefit all of us, particularly your mental health piece. It's going to really help all of us. It's going to help everybody.
No question about it. But again, thank you for your support.
Thank you.
Mayor, I also think that this community needs to understand what you do when the people that you work with and you put your faith and stock in come to us, whether it's a city employee, whether it's a firefighter or a police officer. You are an incredibly dedicated person to the people you work with. You are welcome back here anytime. You can come and visit. You can come and talk to us. You can meet with us as you have. I want to also thank you on behalf of the 6,500 employees. What you did for our bond package was phenomenal. And you can come and stand with your back to us anytime.
Thank you. Thank you all.
Mayor, thank you again so much. Thank you. Happy holidays. You couldn't have been a discussion on pension fund with the mayor sitting in the room. Wait a minute. All right, Chad, I'll come back to you then. We'll go to item back number 8 and ask for a report from the medical executive staff. Chad, it's all yours.
I just told Ms. Dorothy that I'd much rather follow the auditor as we go forward instead of the mayor. I'll be brief because I know it's a busy agenda. Several months ago, we came forward with our first allied health group that our medical staff was going to help monitor the quality going forward. That was the perfusionist. As part of the report, I'd like to request this committee consider approval of the Department of Psychiatry licensed clinical social work delineation of privileges. In addition, we're also going to request licensed professional counselors be further privileged as we go forward. And lastly, at kind of a last-minute discussion that occurred, I would ask for the OMFS surgery PA privileges to be tabled, and we'll bring them back next month.
All right. So we'll have to do these, I guess, individually. Yes. We'll go back to, I guess, would be 8A, approval psychiatry licensed clinical social worker elimination. Is there any discussion with Chet? If not, I'd entertain a motion for. Have a motion have a second by Reverend Emerson. All those in favor say aye. And then following up on 8B, the approval of the professional counselor of privileges. I'd entertain a motion if there's no discussion there also. Have a motion by Reverend Emerson, a second by Mr. Bose. All those in favor say aye. Thank you all so very much. Chet, anything else there? Do what? C was pulled.
C was,
Yes, yeah, it's been pulled. We'll now go to item number 9. And is there anything, Michael, there he is. He's back there in the back. Michael, come on up.
I personally have no fear of having my back to That's because people know I will resurrect and haunt them.
All yours.
Holiday spirit, that's what I'm all about. Cheer and holiday spirits.
Well, ho, ho, ho. Let's have them report.
I wanted to really just focus my report on really 2 items, and they're in relationship to the alignment and integration of the organizational goals and how they cascade down to a claim, and how those cascade down further to the various agreements that we have assigned through a claim with our various physician partner groups, such as IES or OMFS. And there has been an extensive amount of work that has been ongoing to ensure that as we design the key performance indicators for our physician partner groups, that they are geared towards pillars, as well as significantly geared towards outcomes and process improvement and utilization and cost efficiencies. Those KPIs, and as I talk a little bit about a claim or goals, those elements are all geared towards a calendar year. So we're finalizing all those elements in place for a January 1 launch. The KPIs have been extensively overhauled compared to previous years, and probably approximately about 50% of the key performance indicators, as well as the key administrative performance indicators compared to previous years, have been totally changed, overhauled, or replaced. Again, with a very significant focus on quality outcomes and true endpoints in relationship to quality outcomes, and efficiencies and cost utilizations. Within the body of the key administrative performance indicators, much of that is built around process improvement, protocol builds, with the goal and hope and expectation that our providers will really be intricately ingrained in driving those discussions around process improvement as they care for our patients and act as good stewards for our mission. On the acclaim side, I've begun to ask all our service lines to have scorecards for each service line. Again, geared towards each pillar that we have and geared towards each organizational goal as they cascade further down. Obviously, I'm looking from each service line that these are things that our providers can control and are in their particular bailiwick. Those elements will then ultimately end up in a global acclaim or goal scorecard. And we have an upcoming physician board next week, which will be voting on these particular things, so I will be able to share in much more detail at the next upcoming board meeting once it goes through the Acclaim Executive Committee, specific details around those or goals. But what we are looking to do are look at things in relationship to chart closure and charge capture on the population health side, considering that population health is really about improving the lives of our patients. We want to particularly focus on our JPS connection patient population, understanding that for that particular population, the reality is that we are at 100% risk for those patients. So really for every dollar saved is a dollar saved. And so we're trying to create composite scores of incident rates around heart attacks and stroke, or post-operative heart attack and stroke, or looking at preterm labor and delivery for our patient population. So to create various composite scores that we can monitor endpoints and outcomes, and then there'd be strategic initiatives built into a variety of those elements. That is in addition, of course, to each quality element that each individual service line will also have to own and be responsible for, in which case we'll also monitor on the claim side a various percentage that'll hit stretch as a indication of what we do across the spectrum of a claim. I'm also challenging a claim as a collective body to really look at what we can do from a research perspective and from particularly to see if there's a possibility to begin to apply for federal research grants using the power of a claim. So it's no longer just an individual department or an individual service, but things that cut across the professions and across the silos and disciplines, so we can demonstrate a collective body of power and quality towards our patients and our various patient populations. And so that's just an overview of a lot of the work that's been going on, particularly over the last month and change as we go into the new calendar year. And I would really be remiss without saying that this could not be achieved at all without all our physicians and our providers and our APPs pulling together, in particular our leaders, and of course our partner groups, really being heavily ingrained in this process, determining what can we achieve, what is best for our patients, and where do we want to move forward organizationally.
Any questions, Dr. Hotchberg? Ralph, go ahead. Sir. Oh, no, go ahead.
Who, on the scorecard, who's keeping score?
So whatever's on the scorecard are going to be things that are measurable, and there are metrics tied to those. And so some of those are based upon reports that have been created through our IT folks, that are based upon improvement over self, or in relationship to national benchmarks and improvement with regards to those. So we will have running reports for all these measures and all these scorecards, which will be transparent and visible across the organization so that people can be able to monitor. Ultimately, the responsible party to ensure that the measures are being met falls within the body of a claim, since we are the owners of all those various contracts. But again, this is representative of the entire scope of work that all our providers are doing across the district.
Any other questions for Michael? If not, thank you very much.
Thank you.
We'll now move to item number 10, which is our committee reports, and the first up would be our Finance Committee, and I'll call upon Chairman Montgomery.
Thank you, Mr. Chairman. We had a finance meeting in November 15th, I believe. We reviewed our October financial report, and we also passed along a couple of contracts that are on our consent agenda for today, and I urge their approval.
Okay. All righty. Sharon?
Good afternoon.
Afternoon.
So our October financial statements were very favorable compared to our budget. You can see here we ended up about 1.7, sorry I did that wrong, 1.7 million ahead of where we thought we would. Not surprisingly, a large part of that is due to some savings that we had in the medical center expenses. For the month of September, as you can probably imagine, we communicate a lot with our directors and vice presidents to make sure that we capture all expenses that are related to fiscal year 18 in September. So there's kind of a unnatural push to get invoices that might have gotten here a few weeks later into fiscal year 18, so that BKD doesn't come in and find them in a subsequent look. So we did have about half of this medical center favorability is due to lower expenses, and about half is due to a positive variance in net patient service revenue, partially because we had about 2.5% of inpatient volume that was coming through, and a bit of a favorable mix. We also had favorability in a claim on their number. They came in at about $630,000 ahead of their budget. Again, encounters for them were about 3%, which created some favorability in their net patient revenue. And then they also have some open positions that were helping decrease some of their expenses as well. So overall, you can see that we were breaking even at about a $328,000 income from operations. When you drop down to net income, that puts us at $1.4 million compared to about a $500,000 loss as we projected. Are there any questions? Okay, thank you.
Sharon, thank you very much. The next committee report will be Human Resources, and I'll call upon Mr. Boast, who's Chair of Human HR.
All right, thank you. We had our meeting on November the 15th, and at that meeting, we reviewed the annual incentive plan for next year and the long-term incentive plan for next year. And we have some policies on the consent agenda that I need that will be approved with the consent. But I'd like to make a motion on the both plans. I move that the board approve the 2018 fiscal year payout of the annual incentive plan in accordance with the Tarrant County Hospital District JPS annual incentive, which is included in the 2018 budget.
I have a motion and a second by Mr. Montgomery. All those in favor say aye.
Aye.
Those no.
Okay.
Thank you very much.
And this is on our long-term incentive plan, our LTIP. The board having determined the earned amount per unit in accordance with the JPS Health Network Performance Unit Plan dated back to 2015. Now, I know all y'all remember that plan. I move that the board approve the payout of the LTIP for the 2015 to the 2018 performance cycle in accordance to the JPS Network Performance Units Plan dated October 15th. And the individual's award agreement entered into the pursuit of their performance unit plan. Remember, every year they meet their matrix, they get units. So it's within the budget, and I'm asking for approval for the payout.
I'll consider that as a motion from Mr. Boast. Do I hear a second or any discussion? Second. I have a second by Dr. Weber. All those in favor say aye.
Aye.
Opposed, no. Dorothy, thank you very much. Those resolutions seem short. I know many of us have attended HR. You have been involved in this for quite some time. I appreciate all the hard work. It sounds like it's very quick, just a couple quick motions here. If you've been attending HR, there's been an extensive amount of discussion and work. So, Dorothy, thank you for your help in that.
Mr. Chair, if I
Yes.
could, on behalf of the staff, Dorothy, we really want to thank you, and also DT Wynn, who's not here. DT played a major part in the beginning of that, comparing us to other organizations. I want to also thank Dorothy and Bill Whitman. That is the closest professionally a married couple will ever come to each other. And I can't tell you how many arguments they had and how many times they hugged each other and how many times they were on the same page and then they were off the same page. But it is a definite Neil Simon play because they are the odd couple. But they did a really good job. And Dorothy and Bill, we owe a lot to you. You guys put an incredible amount of time into that. Thank you very, very much.
No question. Thank you again, Dorothy. And
Thank Bill because this has really been a partnership, and it's one of those that we've had a lot of meetings on, a lot of conference calls, and Sharon has been right in there with us, and I thank all of my HR committee members for being so helpful. Thank you. Okay.
Robert, not to correct you, but the number they had was 42. They had 42 arguments.
Is that what they did? They had 42.
I remember it was 42.
I knew there was a metric on it, but I didn't know
with
if
all
they
this
had
group,
met their
there's a
metric
metric on everything.
Yeah,
We're under the national. We're under the national average.
It's a whole lot more than El Paso.
Yeah, that's right. All right.
Yeah.
Not saying I had any control, but I certainly lost it if I did. Anyway, item number 11, I guess number A is consider approval. I'm going to turn that over to you, Robert, on another one of those appointments.
Yeah, this is straightforward. This is Mr. Rule being appointed to the city of Euless, and we'd all like to reward him for his fine work and allow him to be on this board.
Yeah. I'll take that as, if there's any discussion, if not, I'll entertain a motion. Motion by Reverend Emerson, second by Mrs. DeBose. All those in favor say aye. Thank you. Item number B, and Ms. Clark, you're already there to talk about the letter of agreement for managed Medicare uniform hospital rate increase program.
Correct.
All yours.
So you guys remember back in March, we started to receive increased rates through the URIP program through our Medicaid MCOs, our managed care organizations. When we approved Cook Children's, they were one of the ones that had a time frame on that increase. So I'm asking for your approval today on the amendment with Cook Children's, which really the only change within this amendment is actually extending it through next August 31st. So it's a 1-year extension for those increased rates.
I have a motion by Reverend Emerson for approval. I have a second, Mr. Bose. All those in favor say aye. We'll call that motion approved, and is your question after the...
Not under the URIP program. It's really, and I'll take a minute, it's the uniform rate for a hospital payment. So I want to make sure that, we put up the IGT for our portion and for those partnerships within Tarrant County. And the hospital, these increased rates are how we get some of those dollars back that we have IGT'd. So it's through HHSC. So there's no action, and this does not impact the acclaim rates through those same MCOs.
All righty. We will consider that approved. Thank you so much, Sharon, which will take us to item number 11C. And Bill, approval of the agreement between the Hutchinson Construction and Tarrant County Hospital District. All yours.
Good afternoon. This has been a long time coming. I texted Angie a few minutes ago, but she hadn't seen her text. I asked her when that invasive lab building was erected, and I think it was 15. She'll correct me if I'm wrong. But nonetheless, when we built that expansion to the east of our pavilion, we created some shell space in the bottom area. It's about 6,000 feet, 6,200. So we have been designing and coming up with the walls and the program to accommodate that 6,200 square feet with 12 exam rooms for the ED. It's contiguous to the ED. We've got a corridor that leads back to that area. We're going to do some renovation of that corridor. So when you add up all the square footage, it's about 7,500. So this is coming to you as a recommendation from the Planning Committee to authorize the expenditure of upwards of $4,160,000, of which $2,294,430 is construction funds to finish out that space and add 12 exam rooms to our ED. How do you feel about that, Dr. Schrader?
Please.
Be happy to answer any questions.
Yes, sir. I figured you would. This is a good thing. I have a motion for approval by Reverend Emerson. Any other comments?
I just want to say they may not have wanted to have put that it will improve operating reduce wait time, because anytime you expand, the crowd increases.
Yeah, that's a good point.
You're right.
Well, there's no question, Chet. We'll be very happy.
For a few minutes.
Yeah.
We already have the crowd. So it's not much more.
Mr. Norrad, was that a second?
Sure.
I have a second by Mr. Norrad, so all those in favor say aye. Opposed, no. Thank y'all very much. And
Thank
yes,
you.
much needed, Ralph. You're exactly right. And Chet, I know y'all are going to use it, so, which then brings us to number D, and Ms. Pia Walker. Pia. Ask Angie. No, I'm just
Angie, the question is, when do we think that project will be completed?
Yeah.
Of? I've been around the block. I've been around the block.
The minutes will say 19. Anyway, thanks, Angie. Pia, it's back to you. Sorry, thank you.
Thank you, sir. So this afternoon, I would like to ask for your approval of the stop-loss insurance agreement. The cost for this agreement is $1.2 million. The previous year was $1.123. There is an increase of $119,000, as you can see in our additional costs. That was due to an increase in claims costs. At this time, I would like to ask for your approval of this insurance document.
Pia, I have a quick question.
Yes.
Yes.
I'm not a troublemaker. I totally support this, but I have a question. So,
yes, sir.
And the reason this is kind of on my radar screen is because Sharon and I see this from last year's budget. We had some unfortunate cases that kind of maybe triggered this stop loss. And I'm wondering, sort of in the full context of, you know, the 1.2 million in premium, the 500,000 it's per case, right? Deductible. I mean, those are some really high numbers. Overall, is the ROI there for us? I mean, if we were to add up what all those cases cost, I mean, is this still a good investment? I realize we want to mitigate our
it is.
risk,
Actually, it is a very good investment because the reason for saying this is that we work very closely with our vendor, McGriff & Siebels, and of course we go out to market to see what other agencies are offering as well, but this is great protection for the organization. So as we do look at this, the thing is focusing on a plan around this from a wellness standpoint, looking at, you know, what is it that we do to be able to bring these costs down. So that's something that we do need to continue to focus on. How do we have a healthier workforce? What does that look like? But this is a great premium. We went out to market for this, and we did benchmark this against other agencies as well. So we did do our homework behind that.
Thank you.
Yes.
Any additional questions, Pia? If not, I entertain a motion. I have a motion by Mr. Montgomery, second by Mr. Bose. All those in favor say aye. Thank you so very much. I think Dr. Elliott's up next. Good afternoon.
Good afternoon.
Item number E.
Thank you, Mr. Chairman. Good afternoon, everyone. I've got two things. I'll start with the first one. First, seeking approval for an amendment to the library services agreement between University of North Texas Health Sciences Center and the Tarrant County Hospital District. It's an amendment to our existing contract that will reflect the anticipated market or merit increases that we have for our current contracted staff that's already an existing expense. It would only max up to around 3%, just in terms of annual or merit increases, market increases.
And what's that annual cost?
Right now, the annual cost for the contract, the first year was around $191,000. It would only go up to about $198,000 to reflect that afterwards.
Any other questions for Dr. Elliott? If not, I'd entertain a motion.
Move approval.
I have a motion by Mr. Bose. Second by Dr. Weber. All those in favor say aye. Thank you very much.
Thank you so much. I'm also going to ask.
I think you're also the next one. Go right ahead.
I am. Thank you, Mr. Chairman. I'm going to ask Dr. Melissa Acosta, our Director of Office of Clinical Research, to join me in case there are any questions around this. And we're seeking approval of a sole source vendor exception in a contract with Abbott Laboratories and Tarrant County Hospital District as we conduct a research study, a cardiac research study in heart failure. It's a device that's already approved, FDA approved for Class 2 heart failure, and they're seeking to expand that to other classes of heart failure, which we're excited about looking at that, and we're looking to participate in that. We've actually already budgeted for that, so it's a budget neutral cost. It's in our operating costs, ready to go for these devices, and also has a potential revenue possibility as we look to build that. So we are seeking approval for that and are open to any questions.
How many patients is projected to be in this study?
Approximately 5, and I'll have Dr. Acosta tell a little bit more. 5 devices at this time.
Right. We will purchase 5 devices to begin with, and then we will have regular meetings with finance, and if it is a successful adventure, study, then we will come back to the board and request additional funds to purchase more devices.
How long will this study last before you come
So
back?
the Abbott study, it started in March of 2018. The proposed closure goes to 2023. But we will probably implant till about 2020, and then they will take 3 years to analyze all the data.
I'm just curious how it works, the device.
We have show and
I
tell.
have show and
She's
tell.
got one right there.
Yes.
If you would sit up on top of the table. Chet's busy, so or it'll be warm.
Pass it around, we'll collect it back afterwards.
Yes.
The device.
So the device itself is the size of a paper clip, and it is an outpatient procedure. So it is threaded through the femoral artery, and it goes up into the right pulmonary artery. It sits there, it's implanted, and the patient, once it's implanted, the patient goes home with a specialized pillow. They lay on the pillow every day. That pillow receives the pressures, and then it transmits them through a wireless to the physician's office. And then the physician can review all the pressures. And if the patient's pressures are going up or down, then the physician can contact the patient and provide medical advice, whether they need to come in, they might need to increase fluids, take different medication. And it has shown a reduction in hospital readmissions, which would also be a cost savings for us as well.
They had it to me and it started blinking. Does that mean something?
Just pass it to the next person.
Yeah,
Don't give it to me. It'll start beeping.
Yeah, thanks a lot, Warren.
One
Yes,
quick
Mr.
question.
McGovern.
One quick question on the
Yes.
Yes.
on the offset insurance collections or the net break even. Are we I'm flashing. Do we anticipate any connections patients receiving one of these, and is that factored into that break even assumption?
So it's factored in, and I'll have Dr. Costa talk a little bit more. The good thing about that is that Abbott has agreed to actually give the device, but also understanding that any patient, either a Connect patient or a Medicare patient, has to meet very strict criteria. So there's a lot of inclusion and exclusion criteria to that, including also the care in home. So we'll look at that, and if we do identify someone who's actually met criteria, it can very well be gifted by Abbott to be able to do that.
Great, thank you.
All right, any more questions? Yes, Dr. Boyd.
Dr. Kamath is the PI.
All right. Any other questions? Good.
So you said it is actually on the market, it's being used now?
Yes.
Yeah, so it's on the market for Class 3, so it's FDA approved for Class 3 heart failure. What they want to do is they want to expand the FDA approval from Class 2 to Class 4A. So with that, Medicare has already indicated, it's already listed as a clinical trial on clinicaltrials.gov. Medicare has already approved that they would cover it because it is an approved device, and the study has gone through them. So they have indicated that they will reimburse our fees associated with implantation of this device. But because it is FDA approved, we do need to purchase the devices, and then we submit for reimbursement to Medicare.
Is the patient given the option of to receive or not receive?
Yes, absolutely. Yes. There's a long conversation between the patient and the physician. So Dr. Kamath and the clinical trial coordinator, they would have a very long conversation. The patient has to consent. They're given a very, the document is about 12 to 15 pages long of all of the possible outcomes and what they're doing. So they're giving a lot of opportunity. So.
Yes, Rex.
I don't practice anesthesiology anymore. And so this year I decided to take some of the type of CME. So I took 31.5 hours of internal medicine CME, which I have completed. One of the things that I learned about in this CME was this device.
Oh, great. All right. That's
There you
great.
go.
All right, Dr.
It sounds like a good deal. Any other questions or comments? If not, I'd entertain a motion. I would say the minutes need to reflect that we're not only approving the purchase, we're also approving the exception to bid, so the minutes would reflect that. So,
Yes, sir.
If not, I would entertain a motion. I have a motion by Mr. Fisher, a second, second by Dr. Iyer. All those in favor say aye. Approved. Thank you very much, ladies.
Thank you very much, and happy holidays, sir.
Appreciate you bringing that was neat too. Item number G, I think Mr. Carr here, Kenneth, there you go. Number G. Kenneth, good afternoon.
The board today to consider the approval of the First Amendment and extension of the product supply and service agreement between our friends Praxair Distributing Company. They're the industry leader in medical gas, and we purchase most of our carbon dioxide, helium, nitrogen, and oxygen from them. The cost is approximately $450,000 per year, and estimated over a 4-year term of about $2.2 million.
Something we have to have. Any questions for Mr.
So
Carr?
this is the First Amendment, it's just an extension of existing.
Yes, existing contracts being extended.
Same terms, yes, sir.
Yes. Have a motion for approval, Ms. Montgomery. Second by Dr. Weber. All those in favor say aye. Thank you very much. Passes. Number H, Kenneth, go right ahead.
Yes, sir. Bring before the board to consider the approval of sole source exception and service agreement with ZM Imaging, Tarrant County. It's a service agreement. It's the cost is $34,200 and is included in the 2019 budget. It's a term for 3 years at a total cost of $102,000.
Any questions for Mr. Carr?
I have a question.
Yes, Dorothy.
I see that we are recommending giving this company a 3-year contract, but they won't even honor us by filling out a form. So I'm a little concerned that if you look at our diversity form, that is nothing, but it is required for somebody to fill it out. If they won't even bother to fill it out, why should we give them a 3-year contract?
You can try.
Well, I just think that if we say that is part of doing business with us, that if we continue to do business with a company and give them a 3-year contract, it's saying you don't have to worry about it.
Well, one of the things that there's not a whole lot of other places that we can get this service from for this instrumentation. If we do go outside and try to get
Kenneth, in all fairness,
okay,
and I appreciate where you're going. I think the point's well made. If this is not an emergency deal, why don't we back up and we pull it off this one, just roll right on, and we'll bring it back after we get that information, Dorothy. I think the point's well made.
And Kenny, you'll have a great opportunity, I think, to go back to them and say, we met with the board, and this issue came up at the board, and we'd kind of like to know your opinion on the go forward.
I think that's a perfect deal. Ken, if you do that, be fine. We'll bring it back through. Dorothy, I think the point's well made. I think they owe us the courtesy of filling out our forms. Ken, go ahead. I'm sorry.
But we don't want to fill out the form to please us. We want to fill out the form to put it. We will make an attempt and an effort to comply with our purchase policy.
Yeah, point's well made. I go back to what Dorothy said. The issue is this board would have to approve it, the contractual side of it, but we're also approving exception to the bid process ourselves. So I think the point's, Kenneth, if you'll come back with that one next time, that'd be great. Let's take the next item, which is item number, you're up for the, what's the next one there? I apologize. I guess it's H, it goes to I?
Absolutely.
Okay.
So before us today is for consideration and the approval of the continuing of the professional services agreement between HHS Environmental Services and the Tarrant County Hospital District. HHS is our provider that provides the comprehensive cleaning environmental service as well as textile processing and service management for the entire district. The overall cost is a little over $11 million, and a little over $10.7 million is included in the budget. The variances of about $300,000 will be offset by the operational expenses. I will make it up. There was an increase in $512,000 increase over the previous year. It was primarily due to the fact that we increased the minimum wage by $1, and it's in line with the overall JPS, but it's also to be competitive in the market because the EVS staff they can jump around from place to place. Also, too, the increase was due to the fact that we opened the Northeast Clinic that we added to this. And then the other piece was the 2% CPI. This is actually covered under our GPO, first choice.
So we maybe just misestimated during our budgeting what their increase would be this year.
Yes, sir. In the increase, but also the Northeast Clinic as well. And then we were the ones that actually wanted to increase the wage by $1 to be in compliance.
Okay. Right.
Okay. Any questions for Kenneth? And I'd entertain a motion.
Move approval.
Have a motion by Mr. Bose, a second by Dr. Hire. All those in favor say aye.
Aye.
All right.
All
Thank
three.
you all very
Kenneth,
much.
thank you very
Kenny,
much.
that's your first time for big contracts, and you won 2 out of 3. That's not bad. So, there you go.
I'll bring the other one back.
Bring the other one back, thank you. That now brings us to item number 12, which is the consent agenda. You've all had access to that previously, so if there's any questions, we'd be glad to entertain them. If not, I'd entertain a motion for approval of the consent agenda as those presented.
Move approval
Have
of
a
the
motion
consent
by
agenda.
Have a motion by Mr. Bose. Have a second by Reverend Emerson. All those in favor say aye. Thank you very much. Goes to item number 13. Does legal counsel have any?
Yeah, the only report I've got is our monthly report on contracts that were negotiated under 500,000. There were 35 of those, and those are posted. That list is posted on your website. If you have any questions, give me a call.
Okay. Which would bring us down to, I have been advised, the only thing we currently have for closed is our privileges. And so we will go to closed at 2:40. I've been advised several people do have other appointments, and with the board's permission, we will go to close so the staff can step out, let us do close. I don't think it'll take very long, and we'll wrap this meeting up. So let's just take about a 2-second or 2-minute, and we'll convene right back and finish this up. Okay, good deal. Ralph, will that get you on the time? certainly in the holiday mood here at the district today. Here we go. Chuck, get back in the fold here. All right. We will now reconvene in open session at 2:50. Is there any other business to become before the board?
So, Mr. Chair, I have in front of each of the committee members the medical staff credentialing activity and would like to request approval.
Any discussion with Dr. Schrader? If not, I'd entertain a motion. I have a recommendation by Dr. Wepper and a second by Dr. Hire. So all those in favor say aye. Opposed, no. And therefore, there being no additional to come before the board, I would say happy holidays and the best to each of your families again, and hopefully see y'all this evening, and we stand adjourned. Thank you very much. All right.